All right. Hi, everyone. I'm Adam Yala. I'm one of the CPH faculty, and I'm very excited to be helping moderate the panel on scaling the frontier. Here we brought together some amazing both faculty technologists working at the edge of what is possible in AI today. This includes both totally new directions the way we build models. We're going to learn a lot about models that understand clinical behavior. The most widely used models, as you've heard about over and over again today, both OpenEvidence and ChatGPT, and models to advance how we understand the science of neuroscience also as a kind of core AI problem. So I'm very excited to bring these people together, and I'll just pass on the floor. John, you want to go first?
I have a nice big timer, so I'll know. All right. So, all right, I'm go. So what I want to talk a little bit about, obviously there's a lot of things I could do, but 3 minutes isn't much time, is a problem we're working on in my group at Berkeley and joint work with Maya Peterson, who many of you know, all of you know, really thinking about new ways to conceptualize what AI can do and how you might train an AI, taking kind of the realities of the healthcare system and behavior into account. And so this is my effort to make one slide that will work in 3 minutes. It's not fantastic, but there you go. I think the basic idea is if you look at kind of where healthcare AI today is really focused, it's doing amazing things. I mean, as we just heard from Bob's phenomenal talk, like there's an amazing opportunity, right? But the focus has largely been, I think, coming through this conventional wisdom, and in part driven by the fact that the technology is rooted in language, is we have focusing on information processing, individual decision making, kind of reading and summarizing patient records, answering even clinical questions. These are incredible capabilities. They take the individual human actions that make up medicine and make them more efficient, more effective, different. And that's important. But I would argue that that's kind of not the central constraint, or not the kind of thing that one might fully reconceptualize how AI can actually transform healthcare. And I would argue that the way I think about this systematic information is the fact that intelligence, if you think of intelligence in medicine, you zoom out to a system level, right? It's not any one clinician making any one decision. The intelligence is embodied in this incredible organization, which is the healthcare system, and in the tacit learning of those hundreds of thousands of providers across the continuum of patient care. And when you conceptualize healthcare that way, you start to think about intelligence that changes care coordination, trajectory management, and starts to get into counterfactual reasoning at the level of a system actually is something that could be kind of the next step in terms of what we're focused on here, which is scaling large models. And to put that in perspective, what I really think about is that an opportunity is building a world model of healthcare. So if you think about world model, right, that's used in lots and lots of different versions of it. But I'll use an example. If you think about, we already heard mention of Waymos, the Waymos that got many of us here today. They are a rodent agent evolving over time, right? They're building and learning actions, and those actions are planning and routing and navigating you through a space. It's not any one individual decision. And they have to simulate, for example, what is the alternative? If I, speed up and there's a cat in front of me, what's going to happen to that cat? They may or may not be particularly good at that, but. And we think of building a so-called large clinical behavioral model as an alternative approach to doing this, that essentially building off of the knowledge of sequence of actions can actually give you a fundamentally new approach to intelligence that is built at the system level, that actually understands not just any particular clinical task or information, but actually how real clinicians treating this real patient now would navigate them through the system. And I think as we build to that, it actually even opens up new approaches to causal AI, just ending on work that's joint with Jonas Connect of this program and Maya Peterson as well. So look forward to the conversation.
Great, that's really exciting stuff. So we'll talk about kind of what we're doing at OpenEvidence and what we built and how it relates to this conversation. So, when you talk to physicians and think about burnout and what's really frustrating about their job, I think the two big things come up. One is documentation, and the other is information retrieval. And medical information retrieval is something that I've been very excited about really since residency, coming on and realizing how frustrating and hard that is. And so at OpenEvidence, our big goal is this idea of medical information retrieval as it relates to primary evidence. And getting physicians, we're publishing so much information right now that a lot of physicians in clinical practice actually have moved further away from primary evidence because they don't have time to do it during clinic. And we're trying to bring that back in a way that people can go back and look at the primary information in an easily retrievable way. And building tools to answer questions and then show the references and the evidence behind those questions in an easy way that people can do every day for every single patient. And so, this has really expanded. Now we have about half the doctors in the country using us for clinical care. And, one thing that we've been very excited about now that we have this power of about 200 million questions tied to the physicians asking them and their specialty is understanding how we can start to generate knowledge with the groups that are responsible for publishing to meet the clinical knowledge requirements of physicians where they're at. So taking the knowledge requirements that they are actually showing us on day to day and working with expert groups to find answers to those questions if they don't currently exist. And so we'll talk about a couple projects along those lines. So, just to give a background of what that data looks like, this is the who's asking questions in OpenEvidence. And we can look for each type of physician, family medicine, emergency medicine, what kind of questions relate to intent are they asking? Are these diagnostic questions? Are there treatment and management questions? And one thing that I like to say anytime I get a chance is these are not diagnostic questions in large part. It's going back to what Bob was talking about. These are medication management questions, dosing questions, what is the right treatment questions. Those are the questions that physicians are relying on AI tools for. And so we can start to fingerprint these kind of intent questions as well as these kind of knowledge questions across medicine. And so I'll skip ahead a little bit we can start to get these kind of roadmaps for clinical knowledge requirements across the entirety of medicine and then use that information with the guidance of experts to derive new answers to those questions. And so creating these fingerprints, both within a specialty and within an individual, to help guide where they should look for knowledge next. And we're doing that through guideline gap analysis for what information is required so that guideline committees can publish that information. And we're also doing that through AI-assisted living guideline deprecation reports. So basically, every week knowing when specific parts of guidelines are out of date so that the committees can update them.
Okay, thank you.
Hi, everyone. I'm Karan. I lead our health research team at OpenAI. So I wanted to give you a whirlwind tour of what we're doing in health. So part of the context and part of the motivation for why we're doing anything in healthcare is that there's a bit of a transformation in how people are interacting with health information on the internet. And you can see Google search trends over time. Year-on-year traffic might be down roughly 10% in most categories, but for health, it's down about 3 times more. And at the same time, more than 230 million people now are turning to ChatGPT weekly with health questions. So this is tens of millions of daily queries, and a lot of this is happening outside clinic hours. And so this is people turning to this resource when it's not as easy to access another resource. And we recently also shared kind of our work on the product side with ChatGPT Health, which is kind of a secure, personalized place to share, to put in your personal health data, and for ChatGPT to provide more personal and helpful responses based on that. We've also been working on ChatGPT for healthcare, which is kind of an enterprise health system-facing solution for bringing some of the best of clinical-specific solutions to ChatGPT. So that includes things like so it includes our work with a bunch of leading partners and institutions across the country, including UCSF. And it includes our work on, for example, evidence retrieval. So now ChatGPT is able to pull citations and medical guidelines from millions of sources. And it also includes skills specific for healthcare. So this is something actually that UCSF is rolling out now. So maybe some of you are already starting to use it. And so we're really excited about that. I also wanted to talk a little bit about the foundations for some of this work. Before doing any product in healthcare, OpenAI spent about 1.5 years really focusing on building the research foundations and the evaluation foundations for our work in healthcare. And so we've built our models and our products in partnership with physicians. And so one example of that is our work on HealthBench, which is this evaluation of 5,000 realistic health conversations with models and either users who are lay users or health professionals. And this is measuring about 49,000 different unique dimensions of performance and safety, whereas most existing evaluations measure just a few. And the result, we've been investing now in every stage of our model to do specific training for health for the last couple of years. And our models have improved quite a bit over time. So our models, to my knowledge, are the first and only models to this day, frontier models, that have dedicated health training throughout the entire model training stack. So we're getting the best of specialized models and general models that are also just good at doing things like writing and reasoning and things like this. And the models have gotten quite good over time. We've also aimed to understand the real-world impact of people using these models in practice and create a clear template for people to do so. So last year we ran what I believe is the first real-world study of an LLM-based copilot used in real-world clinical care to affect diagnostic and treatment outcomes with our partner Panda Health. And what we saw is that when we did this, we saw a reduction in diagnostic and treatment errors as well as history-taking errors for the clinicians who used the AI versus the clinicians who didn't. And one of the most interesting things that Eden showed on this slide is that the clinicians who used the AI actually made fewer mistakes when they weren't using the AI than the clinicians who didn't have the AI. So there's actually this kind of educational learning effect that happened as a result of people using the tool, and I think that's within the realm of possibility if the tools are designed well. Thank you.
Thank you.
Yeah, thank you so much. Very exciting talk. So yeah, dementia is on the rise globally. And in the US, only about 20% of patients receive a diagnosis from a specialist, which means that most diagnoses are done at late stages of the disease when patients can no longer benefit from disease-modifying therapies. The diagnosis of dementia is quite complex. It's multidisciplinary. It needs data from patients and informants. The diseases have multi-layered trajectories. The criteria is constantly evolving, and the gold standard still remains autopsy-confirmed neuropathology. Building those systems, we realized there is a real need for specialist models beyond large language models. I'll give two examples. One, models to really fine-grain extract brain atrophy patterns or resting state functional connectivities from neuroimaging, and also models to extract fine-grained speech features from language that can be extremely helpful for early diagnosis. Not to mention other modalities like genetics, omics, wearables, and sleep. So we definitely need some sort of a sophisticated orchestration to combine all of these systems or models, and LLM suddenly became very good at coding, like really good. So here's one of the projects that we are building at the lab, which is to empower clinicians and researchers in medical reasoning and also scale specialist level care. So this is basically an AI agentic system that has access to different resources. For example, foundation models for neuroimaging speech. We're building other connectors with EHR, genetics, omics, and sleep. The agent has access to different tools like machine learning classifiers that can generate calibrated probability of class belonging. And they can be pre-trained or trained on the fly and then fit to the single subject level. And then also models or tools to help to validate diagnostic claims in scientific literature. We also engineered a lot of data by curating diagnostic criteria and distilling clinical knowledge from a highly deeply phenotyped data set that we have at the UCSF Memory and Aging Center. And I think importantly, we also are testing different kinds of workflows that are reproducible, and then it's easier for us to see the reasoning traces of different models or how the agent is navigating. So we are building a CLI, a command line interface, that is basically a Gemini fork that actually orchestrates all of this, which is already connected to our database. And now we are building several MCP servers or connectors to be able to access different databases while the model is reasoning. And we are now working with clinicians, a team of 17 clinicians at the UCSF Memory and Aging Center to try to build a front end to integrate with the EHR. I'll just highlight a couple of examples of results that are encouraging us. So the system is now quite good at classify clinical and pathological diagnosis of several dementia types. This one is particularly hard, primary progressive aphasia, that we tested the model, specifically trying to diagnose different subtypes of neuropathologies that presents very differently clinically. And of course, the model not only show that it's pretty good, but also faster than humans. And then what we are more excited about is that we expose the system to very highly challenging cases from our clinical pathological conferences. And as you can see from the last row, in some of these cases, only about 8% of the audience, which are world-class specialists, can diagnose correctly, and the system is able to do that. So exciting times.
Thank you all for the great talks. I'm excited to dive into the discussion. So John, at the beginning, you kind of mentioned what is a quite different approach in the idea of how one can be building these models in the first place, right? Looking at more clinical world models, and something that we think of as the vast majority of clinical evidence and events happen not in the trials or the evidence that we know about that's represented in our literature, but in the health systems themselves. So I'm curious to hear the panel's thoughts on, like, directionally, as those models grow, what that would mean for both our health evidence system. What would something like OpenEvidence look like in that world, and like, is that the right technical direction? So hearing a bit more about like the clinical world model direction, and what does that mean relative to the products that people know and love today?
Yeah, I mean, we get OpenEvidence perspective on it, which I think there's a lot of complementarities. I mean, I think there, like a lot of the stuff we're learning in AI, right? To have intelligence, right? There's lots and lots of different components, and I think that's absolutely going to come into this. I think what's exciting to me, and really starts with that paper that we mentioned, kind of the early theory of the ability to basically do new forms of causal inference using these generative models just over a different space. So I am really excited and optimistic about the ability to actually learn knowledge that is both more flexible and more unique to patients that we never have before, right? There's a doctor or a team of providers who are managing multi-comorbid diabetics in low-resource settings really, really well. And they're doing it with a bunch of idiosyncratic differences in medication adherence, things that probably look exactly like not adhering to guidelines. There's neither the platform nor the ability for them to scale that knowledge today, and who benefits from it. You know, their panel does well, but that's something we'd love to drop into low-resource settings around the country, for example. And that doesn't mean to say that guidelines are clearly built where on real evidence and where we want to deploy them. So I think there's going to be a complementarity, but I am really excited about the ability to learn real practice in sort of the realities of the space. You know, much like a self-driving car. If we loaded up the driver's handbook, we'd know all the rules, but that Waymo would probably not make it very far, and so you have to have those rules in there, right? You don't want it veering across the lines, but you also have to have, you know, how would Mr. Yala steer the car as he goes forward.
Yeah, I hate to break, I'm not going to give you OpenEvidence opinion because we aren't a board yet, but I will give you Travis's opinion. And Travis spent a lot of time in real world data and the excitement of that. And most part I'll agree. The way I think about it is there's kind of two barbells in the way people practice right now. And the goal of tools like OpenEvidence is just getting everyone up to the mean, right? So there's a lot of care that happens across every health system setting that doesn't meet standards of care. And that's not necessarily due to any specific deficiencies of the individual, but a lot of due to all the resource constraints around time and availability that we talked about. So getting up to standard of care, which is really all the things like guidelines and primary literature can tell you, is one half of the battle. But the other side of that barbell is all the ways that we can personalize that go outside of the randomized controlled clinical trials. And there's nothing, the resolution of the primary literature only goes so far. And you cannot get that from anything published. The challenge, I will say, in the real world data that I've always experienced is that there's lots of variation in practice, and there are a lot of variation in outcomes. And like you mentioned, determining the causality for that is really, really challenging, given all the dimensions and the variability or variables that go into real-world practice that basically get siloed out from the randomized controlled clinical trial. So I'm very excited about that approach. That's why I continue to do research in it, right? I love it. The predictive models that you can develop with real-world data is something you would never be able to get from published literature, but also lots of challenges that go with it. So I totally agree it's complementary.
Yeah, Karan, I'm curious, like, I guess broadening out the question, in a way it asks, what are we missing from the current types of technologies that we're built to push what's possible in the evidence frontier? Because retrieval can only, as you mentioned, get us so far off existing knowledge. I'm curious, you mentioned that there is a lot of health-specific training across the full OpenAI stack. How you think about this, or the perspective you want to share on pushing what's possible in clinical care beyond like leveling up people to what we know?
Yeah, I can give a little bit of a kind of ML researcher perspective. Is this working?
Yeah,
cool. I can give a little bit of a ML researcher perspective. Let me start a little bit with the model layer. I don't view kind of real-world data and evidence as attention in any fundamental way. I view them as both kind of complementary sources of the kind of data that can feed scaling laws. So for those unfamiliar with scaling laws, it's this kind of idea that as you scale data and compute into models, that their capabilities, whether that's math reasoning or medical reasoning or medical knowledge, that can kind of predictably improve. And so just as people kind of feed the internet and publish papers into models, and both of them are complementary sources of making models good at math reasoning, I view kind of the combination of real-world data and published evidence as both very useful for kind of improving models' underlying raw reasoning capabilities, and that includes their ability to retrieve the relevant evidence. And then at the product level, that shows up in I think two ways. One is models that are just better at doing the reasoning or the task or the knowledge, just maybe better at knowing when is there a lack of medical consensus, or when should I draw on my bank of real-world knowledge. So those kind of models with improved capabilities. The second is even at inference time, you can, in addition to doing retrieval from published sources, you can actually think about doing retrieval from real-world data, and think about for patients with X, Y, and Z who have seen in the past that this health system, what % had X. And I think that's an interesting question, and also an interesting frontier for how people use real-world data.
Yeah. Pulling up the other question. So a big part of most conversations about thinking about like pushing what we can do in the models is always how we think about evaluation and the leaderboards that we use. So I'm curious across your different lines of work how you think about both the internal private evals, what makes it good, because the systems are changing so fast and the usage patterns changing quite quickly, what you want from them, where community benchmarks and kind of like shared infrastructure tooling is useful and where it's kind of lacking. So I'm curious how you think about what is the right evaluation given the standard of care itself and physician review is not perfect, and the variability that brings up. Pass that to anyone who wants to take it up. I'm going to assign. You want to go first? Kind of sharing the perspective on maybe your evaluations and how you think about the kind of agentic orchestration, and like, are there good community benchmarks to build on, and like, what does this mean? Like, basically, what should we be doing as a field to support the development of these tools in the right direction and better?
Yeah, no, for sure. Can you hear me? Yeah, no, yeah. I've been thinking about that a lot lately because this is kind of what I presented. It's kind of like version 2 of the system that we have been building over the past year. And there we had a little bit more clear path for evaluations because it was more of a workflow-based kind of system that was kind of easier to like think about ways of let me ablate this component of the system and see how it performs, or let me not give some data and see, let mask me some data and see how it goes. But now the thing has scaled to the point that we can add so many different components, which is kind of the idea is to emulate how a clinician is reasoning and taking data from different data sources and integrating that in their own clinical reasoning. And suddenly the evaluation probably becomes way more complicated because, for example, for every time that the, let's say, system is retrieving a foundation model that was then fine-tuned for a downstream task like predicting if a patient has MCI or not from a brain imaging scan, you can test that, let's say, system that model in isolation that was, let's say, pre-trained somewhere else and see if it fits in your data of your center. But when that tool or that foundation model is within an agentic system that is also integrating data from other sources, how do you know if that evidence from that particular component is helpful? So I think that's one part of it. I don't think that for the kind of applications that we are more interested, which is really like patient real data that is complicated, that is tertiary clinic, for example, in our case, that you have data from different data sources, brain scans, omics, genetics. There is no currently publicly benchmark for that. That would be able for us to, let's say, test some of these before. As we develop, the approach that we have been doing is to take our data and use that as the development of the system, and then have other data sources that are external for us to test in several different ways. So, yeah, it's. And then that it's becoming closer to, let's say, how do you assess what a memory and aging clinic does? What are the challenges to assess how well a clinic is doing with their patients too? It's like these systems are getting close to emulate probably like a lot of the things that a clinician will be able to do, but how do we access that with humans? Like how are those things? Like I'm not asking any doctor to say not use this particular model and see how it affects the general like the diagnostic performance of the clinic. So I don't know, I think this is kind of going to move towards some sort of like a real world kind of testing, a system level that it's not only the algorithms themselves.
Do you have any, from your perspective, seeing hundreds of millions of real physician behavior in the world, how do you think about both evaluating, like, as systems improve, but also when systems are
Yeah, so let's talk about
deviating
evaluation.
from the
I think it's really, really challenging, and I'll talk about kind of internal benchmarks and external benchmarks and why external benchmarks are so hard. And I think it all comes down to the shelf life of the evaluation tool. And so I'll give you some examples. So differential diagnosis, which is like, okay, you give a few symptoms and you create a differential diagnosis. That has actually a fairly long shelf life, because we don't come up with a lot of new diagnoses a lot, right? And so the shelf life for a diagnostic evaluation tool is, or a diagnostic set of differential diagnosis is actually fairly good. Like you create a benchmark, you can use it over and over again. But that is the exception and not the rule in medicine. And so, for example, if you wanted to create a wayfinding tool, so what's the right next question to ask for a differential diagnosis, that shelf life is actually shorter, right? Because we have different procedures that come up. We have different diagnostic tools that come up. It's still pretty good, but it's a little shorter. And then you think about treatment and management, and that actually has a very short shelf life. And we have to constantly update our internal evaluation metrics because treatment and management changes. And if you created an evaluation tool for what is the right answer for this, for treatment and management, 5% of those questions could be wrong, actually, really wrong, and have changed since the last time you did the evaluation. And then the final step for us, the ones that have the least shelf life, are references, right? So even with the right answer, what's the right reference to give for that right answer? And given how fast things publish, that shelf life is even shorter, right? So the problem with setting benchmarks, and so this when it comes to like internal versus external, is we constantly are having to update our benchmarks. We can't have a static set it and forget it set of questions and answers that we can trust 100%. And it does depend, like I talked about, the shelf life of these different parts of medicine. But then you think about external benchmarks, and that just becomes really challenging. Health benches, I think, a great example. A lot of those are diagnostic and a lot differential diagnosis, and they actually stand the test of time because of what the focus was. But for us, that's been one of the challenges is for evaluation. How do you keep the evaluation set up to date, given how fast medicine changes?
Yeah, I mean, just echoing a lot of what's been said, I think it becomes incredibly important to start to have evaluation that's in some kind of real world. And I think one important piece of that is that it's going to be messy and pretty bespoke to whatever the thing you're actually testing for. So this idea that we're going to get like universal leaderboards, I think is somewhat naive given the complexity of the realities of the healthcare system, and we've sort of gone in that direction. And you heard it even in Bob's conversation about what should we be testing students on. It's natural to say, oh, if I can replicate a student at the end of medical school, that's pretty good. Like, that's a pretty good thing to have. But of course, we all know that's exactly the point at which you go out into the real practice of medicine and learn how to actually practice medicine. And so I think or just a one-shot diagnostic case. It's amazing to be able to do that, but that's a one-shot interaction. And how do the aggregations of, for example, noise in those go through a patient's journey, right? That you would inherently miss that. So this is not to say it's not solvable, but I think it's going to be maybe messier than just saying we all have one leaderboard and you know, this model goes up it and this model doesn't, kind of thing in health.
Do you have any checks to share? If we were to build Health Bench 3, you know, directionally, like, what are we missing? Because something we talk a lot about in, like, my research context, like, things we think a lot about in academia is, well, how do we steer the future, know we're building the right direction? And a part of that is measuring. It's kind of fundamental, but it'll always be somewhat bespoke and fragmented. You know, like, measuring care improvements here at UCSF is going to be different than the absolute need of what we have. So as you think about improving things everywhere, because the usage base is so wide, like, what types of tools should we be building as a community to help make this easier, even if it's fundamentally always going to be not one number, but the combination of many fragmented numbers?
Yeah, I very much agree with that philosophy. I mean, I think we view figuring out this question as a moral obligation for us at OpenAI, because we have billions of health queries a week, more than any other platform, maybe other than Google search to my knowledge. And so whether we can measure that and improve that in the right direction is a very, very important question. So obviously, as engineers and researchers, we like one single number to the extent possible, but I agree with the sentiment that it's very hard to collapse such a multidimensional thing into a single number. That said, when we think about evaluations broadly, we try to hit 3 criteria. One is we want the evaluations to be meaningful, which means that if the number improves, human health will improve at the scale of use of our tech. The second is that we want the evaluations to be trustworthy, which means that they're backed by, let's say, the consensus of experts. The third is that we want them to be challenging. And this is actually, the third and the second thing are actually a bit of tension sometimes, because for an evaluation to be challenging to our models, especially for our models at the frontier, often the issue when that happens is that the evaluation is wrong. So often we can compromise on 2 and get to more challenging looking evals, but then actually the eval was flawed in some sense. So that's kind of broadly how we think about evaluations. And, you know, we definitely are like constantly updating our own internal evaluations and things like this, but we also, the reason we put out Health Bench and the reason I think it has stood most of the test of time, I think it's been about a year, which is I think an insane amount of time for an eval to mostly stand up to, is because we wanted other model developers to do the same thing. One of our goals last year internally was, can we get all the other people who are working on models to spend half as much time as OpenAI is spending on our models in health? And so I put up that chart on Twitter some time ago just to pressure the other labs to do it. And I think, as an example, I think Meta is now roughly there. And Google has like 100 people working on it. I think that's very exciting, and I think that's, you know, just to say, I wanted to share that kind of why we are investing in it. It's because we view it as like something that can causally improve a lot of lives.
That's cool. That's a compelling demonstration of how one tweet can change a lot of priorities, you know, Twitter for social change. So I want to shift gears a little bit, thinking about both deployment in the future and like priorities for folks in this room. So something that's very exciting to me, having been at this conference last year, is I feel like a lot of our conversations back then was like, well, what does it take to like scale the impact and like, you know, help many people in the real world? And something that's changed dramatically in the last 12 months is the scale of usage and that impact. I mean, like both the growth of OpenEvidence, but also like the usage in chat for questions in health. And something that's interesting to me is that some of the conversations before was like, well, the pain of Epic. And it seems like some of the big successes have simply ignored Epic. So I'm curious more generally for like folks in this room, like any lessons or how you think about deployment to kind of that path to impact today, and things you think about in both the growth of your own projects more directly, but what it means for us structurally, and like what's the role of Epic into that future? If anyone has a...
I think for both patients and clinicians, the situation is in some sense quite dire. So for patients, about 50% of Americans don't have a regular primary care doctor. A large percent also report difficulty accessing care easily. That is true across the world, about also 50% across the world. For clinicians, you know, burnout, administrative burden, you know, people are spending a lot of time on paperwork, you know, margins are short, people are squeezing in more and more visits in less and less time. I think people are turning to AI not because it's an easy thing integrated into some existing software workflow that they have, but because it's almost their last resort. And I think one of the things I hope for is that as the value of AI becomes more and more obvious to patients and clinicians and the makers of software that serve them, that the incentive landscape becomes such that the makers of software who serve them also integrate more AI into the software.
Yeah. I agree with all that. I think I can see it going a couple different directions in the next few years. And Bob and Sarah and Julia published what I thought was, can you hear me? Oh yeah, a really excellent piece on kind of one of those directions, which is there's an establishment that everyone is forced to work through, which is medical record system. It was not designed for AI, but it can co-opt AI and make it better than it is. And the question is, can it make it better, as good as it could be? And so I think one is we adopt some sort of AI into these existing systems like Epic and Cerner, et cetera. It makes lives easier for both patients and physicians, even if maybe it's kind of like shoving a round peg into a square hole and it's not a perfect solution. I do think there's another one that's an actual total disruption where we have a completely different way of thinking about interacting with health systems, in which it is AI native through building something outside of the EHR, and then having that as a way that physicians and patients can interact in a way that the AI that the patient is interacting with can talk to the AI that the physician has all that information for. I'm not saying that that is a system that we at OpenEvidence are building, but I can definitely see that in a couple years where there's a disruption such that we are not forced into the shackles of what was currently being developed. And that would also, I think both of those are exciting for the physician and the patient, and something that is better than what we currently have, because what we currently have is not great. But I think both of those possibilities remain possible in my mind, despite the heresy of the second.
Yeah, I think this is what's become, I've been working on these kinds of models for a few years now, but what's really exciting to me about the approach of kind of this world model idea is that if you think about intelligence at a system level, you turn out to be able to kind of deploy in ways that don't have to go into any particular decision. And I see a world, at least in the nearer term, where the ability to actually more effectively route, more effectively allocate, more effectively make sure the right information is in the right place turns out to be kind of this Trojan horse in the sense of at the infrastructure layer. And so that is another sort of optimistic view, and certainly one that I've taken in trying to bring these models to deployment, which is not build the full front-end software to, for example, do smarter scheduling, but instead just power it through the underlying intelligence. And that allows you to play nicely with the Epics of the world, but also play nicely with whatever new agents are doing other things. And whether it's us or I think beyond it, I think obviously the AI scribes have an incredible source of an infrastructure layer. It is this moment where these infrastructure layers, it's the first time that I can remember, and I'm sadly can remember longer than I'd like, where Epic doesn't control it all. I do worry about basically the version in which we have a product coming, don't worry, leads to, you add that plus a year of AI review, and you're going to really slow down startups trying to do, or big companies trying to do new things. So that's, I think, the sort of practical worry about that.
Yeah, I agree with everything. I think it's just very clear to me that the way patients and clinicians interact with computers are going to change in general. So we are already seeing that happening so fast, and I don't see where exactly this is gonna happen. If it's gonna be through some of these already big companies on the healthcare space, but it's definitely gonna. There will be a transition between the current systems and systems that are way more capable of accomplishing the tasks that they can do And I'm on a route now to try to like start implementing some of these things in the clinic, and I am already seeing how it's just like it's so hard from so many different levels. Of course, some of them are correct to be hard because of patient privacy and security, but there are so many entities that are in the middle, not only the, let's say, Epic. I mean, I haven't even reached Epic yet, formally. I mean, they actually have some good documentation of how to integrate some of these through their APIs, but first, of course, this is hard, but second, it's just so hard to get into a place in which you can propose to have a tool, and then you can go through all of the governance aspects of it, and it just doesn't seem that this is going to hold for some time unless, I mean, might be hold in some institutions or in some places, and then they are going to just fall behind. I think we'll need to rethink that quite heavily to be able to more seamlessly be able to translate some of the work that we are doing in science or like startups on that space.
So I think we might already be a touch over time, but I want to ask one lightning question to kind of close out the session, and if I think so. Now, we spent some of them talking about what's the future of being an MD given the shape of these tools changing. And something kind of recurring through this conversation is that we can take it for granted that the tools are as bad as they'll ever be. They'll get better much faster. That gives us even troubles on how to do evaluation. It gives us trouble on our AI governance boards. And in just the last 4-ish years, we went from like the first launch of chat to today, which is wild, and like it's more likely that my mom will start using Claude, which is a crazy thing that I never would have imagined. Now, 4 years is actually shorter than a CPH PhD. Yeah. And so one kind of lightning questions I want to ask is, if you were to start your PhD in this computational area today, like, what advice do you give to the kind of early career PhD students in the room today, how you think about building and inventing the future in this ever faster and more dynamic space? But big question, but short answer period.
I'll go. I think what you learn in a PhD, you learn some technical skills, but you never know where your career is going to go, and that's not necessarily what you take out. I think the ability of forecasting in your field is what's most important about what you learn in your PhD, and something like computational precision health, where you can understand where the field is going, both for what things a physician will need to practice and where technology will meet them, I think will be really important as things that someone in graduate school now will learn and be able to use in their next step.
I mean, I can do a very quick version, which is a little narrow, but I think, you know, we haven't talked about the fact that really we're taking kind of all data that's labeled as the same. I think a lot of the future, if you're here now, is the human intelligence and the system intelligence that forms intelligence. So thinking about more deeply, how do I understand that richly, broadly, it will complement a lot of technological and technical skills as you go forward.
Yeah, I think one important thing is to really think about that now something that you're working on your PhD could be fastly translated into something that is useful. So maybe before it will take a few years, and then this will be translated into something that's going to be useful, but now it could be very fast. So I think knowing that and learning how you could leverage that and how you can develop some skills to think about how could this impact the world. I think it could be super valuable. It could be within a PhD, so I think that could be really cool.
I think, so PhD is very multidimensional. I think one very simplified way to project your experience in a PhD in one dimension is how much are you betting on the models or against the models? And I've seen people do PhDs where the way they approach their research, the way they think about questions is they're implicitly taking a bet that the models will get worse or not get better. And I've seen people do the opposite thing. I would generally advise doing the betting on the models getting better. It feels like a pretty sure bet now.
Cool. Well, I think we're already out of time. I want to take some time to thank the panel. Thank you, everyone.